session. So it's 9:40. We're going to get started. I want to welcome everybody to our online forum presented by Communities Confronting Substance Abuse and Refa'enu. We are very pleased to have three people here to talk to you about the subject of mood disorders and share their unique perspectives on this issue. We would like to remind everyone to be respectful of each other's privacy, particularly when it comes to sharing personal stories. During the meeting, you can chat any questions to me, and time allowing it, we will answer them at the end of the session. We'll also be sharing links for you to sign into your next session throughout the chat, so keep an eye out for the links. The session is estimated to end at 10:20. We're going a few minutes later since we started a few minutes late. And I'm just going to welcome our presenters now for you. Dr. Ariel Mintz, Dr. Tzivia Maureen, and Dina Krug-Cohen. Dr. Mintz is a psychiatrist and founder of the nonprofit Refuat HaNefesh. Dr. Maureen is a geriatrician and primary care physician in Stamford, Connecticut. And Dina is a writer and editor, as well as the founder of Refa'enu. Thank you.
Thanks, Debbie. Hi, I'm Dina Krug or Cohen, depending on the context. Today I'm both. I'm a writer and editor and a mental health advocate. I oftentimes write about topics of mental health for the Jewish Standard, which is a local Jewish newspaper in North Jersey, where I live. I founded Refa'enu in 2014. It offers educational programming about mental health and also peer support for people who are affected by mood disorders. Currently, we run a support group over Zoom for people with mood disorders. It's every Tuesday night. If you're interested in finding out more, you can email me, dina@refaenu.org.
Thank you all for joining us. I'm Dr. Tzivia Maureen. I'm a geriatrician. I help care for older adults in the hospital here in Stamford, Connecticut. And I just wanted to introduce my relationship with Dina. She and I have known each other really our whole lives. Our moms were best friends from the time that they were in kindergarten, and just happened to both move together to the same town where Dina and I grew up, and were born just a month apart from each other. And so we have been close for many years. Some of that time went to school together, at other times just had our connection and relationship, and that's a lot of what we're going to talk about during the session. Thank you for inviting me to join.
Hi, I'm Dr. Ariel Mintz. I am a private practice psychiatrist specializing in general psychiatry, as well as child and adolescent psychiatry. And on the side, my big passion is Refuat HaNefesh, which I founded in 2016 with the goal of creating a Jewish community that's more aware, respectful, and empathetic to people with mental illness. And we try to create that change through our blog, in-person conversations, and different community events and workshops. And if you'd like to learn more about that, feel free to visit refuathanefesh.org. But today we're talking about mood disorders. And so I will give you a brief overview before Dina and Dr. and Tzivia get into, kind of the personal story that they have with it. So mood disorders is really, it goes back to prior to 2013 when we had the DSM-4, Diagnostic Statistical Manual of Mental Disorders. They were included together, and it's really a broad heterogeneous group of greater than 10 different disorders. And each of them really have different genetics, presentations, and treatments, but they are all lumped together under the same category. The two main categories within them are depressive disorders, which include about 6 different disorders. Some of them you may know as major depressive disorder, persistent dysthymic disorder, premenstrual dysphoric disorder. Also, there's peripartum disorder or postpartum depression, and seasonal affective disorder. And then there's the broad group of bipolar disorders, which include several different diagnoses as well. And each one of these, even within each disorder, could have various presentations based on the age of the person presenting with it. So we see very different presentations in childhood and adulthood, as well as in the geriatric population, and we'll get into some of that later. But the main thing to know is that these are very common disorders, and in any given year, about 10% of people will have one of them. And in the lifetime, about 20% of people will qualify for one of these diagnoses. We do know that women have about twice the rate generally as men in terms of how often they get mood disorders, with that being a little bit different in the bipolar disorders, with men coming close to equal, as well as interestingly within the Jewish community in the depressive disorders, we see a pretty equal presentation in terms of how many women and how many men, as opposed to the general population where it is twice the amount of women presenting with them. But so now, I'll let Dina and Sylvia tell their story, and we'll talk about more of the details later.
Thanks. I guess I'll start where it started. My first depressive episode. It was the summer before 10th grade, and I was on a teen tour of the West Coast, but Sylvia was there with me also. We were on a long bus ride to go on a hike. We're going through this beautiful scenery. There's burnt orange and bright blue sky. We're going through the canyons and the desert. And I'm looking out the window, and it just seemed like all the colors were muted. And I felt this lump in my throat. My eyes were getting teary-eyed, and I felt this sense of dread that kind of just like washed over me. And I didn't know what it was. I just knew that I didn't feel right. So we stopped. The bus stopped to go on the hike, and everyone's filing off the bus. And Sylvia, I don't know if you remember this, but you came over to me and you're like, come on, we're going. What's wrong? And I said, I don't feel well, which was true. So I stayed on the bus during that hike. So then come 10th grade, I'm still feeling off. I think that sense of dread kind of went away, but I'm still feeling all teary-eyed, and I have a lump in my throat. And I had no energy. I didn't sleep much. I didn't eat much. I kind of would sit in the back corner of the class and either look out the window, kind of trying not to cry, or I'd be writing in my notebook, hiding behind my hair, just so that people wouldn't see what was going on. Also, I would sit on the floor. There was this alcove by my locker. I would sit there doing much of the same, writing in my notebook, poetry, drawing pictures of trees, and just not there. And I didn't have anything to describe what I was going through. There was no word depression in my vocabulary. I mean, I had heard of it, but I thought that I was like the brooding artist or the moody teenager, and I was reading philosophy and looking for the meaning of life and just things like that. I didn't have anything to describe it though.
And I think, I felt as a close friend at that time, felt very similar. Being a teenager is hard, and there are so many changes and thoughts that you go through, and really it's a growth process. So what I saw was just what you described, a moody person. I wanted to be there for you and bear with whatever was happening developmentally, so socially, emotionally. But I think I definitely had this sense that this was more than usual, or there was something more that I didn't understand about what was happening for you. I could tell that something was wrong. And maybe it was a little bit scary at that time too, but I wasn't obviously able as a teenager to recognize what could be happening. And then one thing that Dina, you and I talked about that I did pick up on is that you were not eating well. And there was almost a disordered eating component that came into this. And that's what I was able to pick up on as a teenager, that did not seem normal, that was concerning. Ultimately, I did go and seek guidance from a faculty member, because you and I were in high school together, and I knew that something had to be done, but I didn't know what it was, and I wasn't sure what the problem was. But it was really the disordered eating that was a flag for me, and maybe for both of us. And I think your goal in everything that you do with Refa'enu and all the work of these organizations is to raise awareness. But the awareness includes understanding that even early in life as a teenager, you can start to manifest symptoms. But a teenager and the people around you, and maybe even the adults in your life, may not recognize what's happening or understand that it's more than just that teenage moodiness or angst, and there's more that can be offered and done to support you.
Yeah, I think a lot goes into needing education about these disorders. And you're right, you know, it takes its toll when you're not diagnosed. And so if you're not diagnosed with anything, you can't be treated, and you can't be treated correctly. And I went from not being diagnosed in high school and then finally being diagnosed with unipolar depression in college and being put on antidepressants for that, which were not the right medication for me. And finally, it was 10 years after my initial diagnosis that I finally was accurately diagnosed with bipolar disorder. So this lack of knowledge of what was going on really, you know, it had an effect on how everything turned out.
And I'll, you know, pipe in here and say that what you experience is not at all uncommon. We know that diagnoses typically begin to increase in the adolescence period for depression specifically. We have seen increased rates recently within the prepubescent children. Most often that relates to home and school factors, but that is definitely increasing. But really the average age of diagnosis for depression is actually up to age 40. And there's often a multi-year lag from when the symptoms start to when people get diagnosed. And that's really for two major reasons. One is that once people start having symptoms, they don't often present to a doctor right away. And they may not recognize the symptoms in themselves. There might be some denial about it, but it takes a long time for people to seek treatment. And then the other factor is that very often when people do seek treatment, they get diagnosed. And part of that is because the presentation does vary so much, even within the same disorder. And so for example, when we talk about depression, so children oftentimes will have irritability or they'll withdraw from activities, which is different from adults who, you know, report that they feel sad and depressed. Children don't have that. And then it changes again in the geriatric population where you see more apathy, not caring about certain things, maybe memory loss. And there, when people develop depression, it's often diagnosed as a dementia type disorder. And so there's a lot of difficulty in diagnosing these. And then once you bring in bipolar disorder, it becomes even more complicated. So bipolar is typically diagnosed in the late teens or early 20s, but it's not uncommon for it not to be diagnosed until maybe age 50. And as Dina pointed out, this has big ramifications because the treatment is wildly different. We treat depression mostly with antidepressants, and that could actually make mood disorders worse. We also oftentimes we do see what Dina was discussing a lot of times. It will take, you know, people have a depression diagnosis and then 10 years later be diagnosed with bipolar. But we also see the flip side where people are being diagnosed very commonly with bipolar disorder and then later on go on to only be diagnosed with depression. And I see this quite a bit in my practice with people that have been being treated for bipolar disorder for a long time. And then, you know, when I do a new assessment, I determine that it's not actually bipolar disorder. And to address this, there was actually a new diagnosis that was created in 2013 called disruptive mood dysregulation disorder, which is meant to capture kids that are just, you know, really angry and have a lot of the irritability that you might find with bipolar disorder, but it's a different disorder. And so we've cut down a lot on those misdiagnoses, but now it's more where we diagnose people with depression, and then later on they do go on to be determined to have bipolar disorder. And it's very difficult to tease apart what this is because a lot of the symptoms are similar. And so although Dina's story is not uncommon, it's important, I think, for people to keep bringing up what they see with their doctors so that doctors can continually reassess it and determine if they made the right diagnosis initially or if things have to be changed.
Yeah, I agree that communication with doctors is really important because they're not always going to be able to pick up on what's going on with you unless you tell them. So to continue my story, when I was in college, I kind of was still up and down, well, regular and down mostly, though in retrospect, I noticed that there were some I call hyper moments there. I oftentimes did worse in my first semester academically than my second. I think the weather and the winter months kind of affected my mood, which in turn affected how I performed in school. My first semester junior year was particularly bad. I, was really depressed. I was finally diagnosed with depression at some point during that time, and I was on antidepressants, but I had a really bad semester. So I went to Israel the second semester to kind of clear my head more than anything else. I went to seminary, and I met some interesting people there, and it helped to a certain extent. But 2 months into it or something like that, my mood started to dip again. And I didn't know what to do. I wasn't there as long as I wanted to be. I didn't know if I should stick it out, if I should go home, what. So I asked the rabbis and the teachers there what they thought. And there was only one rabbi who was familiar with depression. And he said to me, go home. Your mental health is more important than learning Torah. Go home. And I really appreciated that. I went home. Things kind of evened out a little bit. Then at some point, a couple of years later, I got married. My husband knew about my depression. He knew that I had disordered eating. There are no secrets there. Everything in the open from the get-go. And I guess a year into the marriage, after I got married, I had an episode that I'd call a mixed state. What was happening at that time was I had a lot of life stressors going on. And the psychiatrist increased the dosage of my medication, my antidepressant. And the combination of the two kind of set me off into this state where I had the negative emotions and thoughts of depression, but then this agitated energy of the mania. Oftentimes people think they think of mania as like this flighty, energetic, going on spending sprees at the top of the world. It's not always like that. I mean, for me, it's always been, or most often has been, agitation and negative energy mania. And the danger in having a mixed episode is you have the depressive thoughts and emotions, but you have the energy to do something negative about it. I never ended up harming myself, thank God, but it was bad. And finally, I had all this chaos in my head. It's really difficult to describe because I don't remember all of it. And two, it's just difficult to explain something going on in your head, but I had all these thoughts going on and my head was there was a lot of noise. It wouldn't stop. And eventually I was diagnosed finally with bipolar disorder. And that only kind of happened. First, I was put on a mood stabilizer and it worked. And I finally got the right diagnosis. And it was interesting when it worked because this is 10 years after that first episode where I was on that bus, on that teen tour, looking out the window and everything had seemed like all the colors seemed muted. And this was like the opposite experience. About 2 weeks into taking the mood stabilizer, things started to lift and I felt more myself than in a way than ever before. And it was the opposite with all the colors. Everything seemed brighter and crisper and I literally see more clearly. And it was like putting on glasses for the first time and realizing, oh, so that's what it means to see clearly. But, it was tough, 10 years, there were tough times.
And I'm sure that many or some of you may be close with someone who's had either a mood disorder, specifically bipolar disorder, and that it can be really scary watching someone go through that, and especially not understanding. And Dina and I did not go to college together, but we were close during that time. And I really just didn't understand what was happening, especially seeing this range of emotions and what she was experiencing, especially before being diagnosed with bipolar disorder. And I didn't know what to make of any of it. And I feel grateful that later on, I had the opportunity to learn a little bit more professionally, going to medical school, becoming trained as a physician about mood disorders. But at that time, I really didn't know what I was seeing. And so it was scary. Even after, I remember Dina telling me that she had been diagnosed with bipolar disorder, and I still didn't understand what that meant and what was that experience for her and how is that going to be treated? How is she going to feel better? And so it's been a process, just watching how you've been doing over time. But I have to say that the big thing that I wanted to convey today was really just feeling hopeful, looking at how we've been friends for such a long time and gone through so many ups and downs, which is normal in life, but particularly impacted by the experience of what you've been feeling and experiencing and how you've cared for yourself. But it makes me feel very hopeful reflecting on it, because even though there have been so many times that were scary or there was uncertainty, and even now sometimes if you have a period where you're going through a tougher time, it's still scary to me, but I feel hopeful because I know that thank God, you're getting the right treatment, taking care of yourself. You have people around you who love you and want to help take care of you. And so looking at the progression of how things have gone over so many years, I really appreciate that.
Yeah, I appreciate that too. And I think, feeling hopeful, that's a good way of putting it. There are a lot of things that you can do to help manage these disorders. I mean, you're not going to cure them. They're there forever, but you can manage them. There's all types of therapy and medication and self-care and healthy life choices and peer support. There are lots of things that you can do. And I think the trick is to kind of have that hope and realize that it can get better from where you are.
Yeah, and then that's really, I think that makes a big difference to both of us. I'd like to say, that you can reach out. There are people around you who really care about you and now understand better what's happening and what might be more helpful to you. And we've gotten to that place through being with each other, learning together, educating ourselves. And I really appreciate that.
Yeah, a lot of it goes into education and knowing. I mean, I'm very open about this illness. But not everybody is. But if you are open, then you can have that support from people from your life because they know what you're going through. Just like if, you have to tell your symptoms to a doctor or else they're not going to know everything. The people around you, anything you go through, I think it's important to share how you're doing so that they know how they can help you.
And I'll touch on some of those points. I think the future is getting brighter. For people that have mood disorders. And nowadays, most people with a mood disorder, whether depression, bipolar disorder, are able to have fairly good lives with work that they're doing and family and good social connections. And they're able to do very well to the point that many people have no idea that they have a mood disorder. The treatments have definitely improved drastically over the last couple of decades and continue to do so. And that's with different psychotherapies that have been developed. We have new medications and newer ones in the pipelines that have less side effects and are more effective, with new procedures that we're doing. And now we're even looking into genetic engineering and being able to, on the biological level, change things. And that's really exciting because that would be the first time that maybe we could have a cure, because regardless of what treatments we do right now, people are able to be stable, but they still have to be vigilant for recurrence of symptoms because they are not cured. They're just in remission, essentially. A lot of people worry about if they have a mood disorder, what does that mean for their children possibly? So I'd like to touch on that for a second. So we do know that there's a large genetic component for both bipolar disorder and depression. In bipolar, the studies range from 60 to 90%, and in depression, it's 40 to 50%. And what that means when we kind of take it apart, so there's still a large environmental component. But if one parent has, let's say, bipolar disorder, where it's more genetic than depression, the children have a 10 to 25% risk of developing depression themselves. And if there's two parents, it's up to a 50% risk. But a large part of that risk is actually still environmental and can be reduced with appropriate treatment for parents. So the best thing parents can do for their children is getting the treatment they need. And that reduces the risk that that trait will be passed on. it's also important for friends, you know, so Dina was very fortunate to have Sivia and other people in her life who were very much there for her. And when we look at prognosis for a mood disorder, study again and again shows that the best prognostic factor is having good quality relationships with friends, spouses, other people in your life. That, to a degree, makes a larger impact than whatever medication you try. And there's a study that's widely quoted that's, you know, I always find very interesting. They found that if a friend sends a postcard to someone with a mood disorder every month, just checking in and saying hi, not even a phone call, not even going and spending time with them, but just a postcard, that is equal to treatment as usual, to them seeing a regular psychiatrist and psychologist. You could get the same effect with that. And now I'm not recommending that if you have bipolar disorder, you come off of medication, then just ask someone to send you a postcard. But the point is that we, as people supporting people, other people out there, whether we ourselves have a mood disorder or whether we just know somebody, we can make a huge difference in other people's lives, and we shouldn't underestimate that power that we have. And so it's just really important to be present, be there for people, even if you don't know what to do or what to say, just be around, and that can make a tremendous difference for them.
Yeah, I'm smiling because Sivia and I sometimes just text each other knock jokes and things like that, just to say hi, you know, a little smiley face. And that really does make a difference. And hopefully for Sivia too, not just for me, just in lifting your spirits, you know.
Absolutely. I mean, we know these days more than ever before, being connected is so crucial.
Yeah.
But definitely the ability to just reach out. And I have to say, Dean, you do this more than I do. You just text me out of the blue, how are you doing? How are things? Or you send me a joke. It really makes a big difference to me. So you remind me that I can also be connected to you.
Thanks. How are we on time, Debbie?
We are good. We have, it's 10:07 and we're ending at 10:20. So
Okay.
you tell me if you.
I think we're ready for some questions if anyone has
Okay,
any.
great. Okay, so the first question that I have is, how has COVID-19 impacted you in terms of your mood disorder and managing everything?
It's weird because when the pandemic started, I didn't get depressed. It was more anxiety than depression, but I kind of felt like, all right, I'm on go mode. I can't let anything, like I didn't have time to be depressed. I'm trying to take care of my family and just life in general. And, you know, you have school at the same time as work and everything, everyone's going through that. But I think that I was a little more equipped than a lot of people who never experienced any depression or that type of stress before, to be able to get through it just because of having some tools to do that. Again, I had some anxiety, but now I guess it's evening out. You know, my mood is back to being up and down, though I'm managing it. But in the beginning, it was okay.
I'll say
Okay.
also that I am seeing that again and again, the experience that Dina's describing, that to a degree, it's almost like people are coming and saying, finally, the world gets it. Like, this isn't a safe place. There's so many things to be afraid about and anxious about. And I've seen most of my patients, I'd say a majority of my patients with chronic mental illness have actually been stable or doing better during this time. But there is a huge influx of people coming to me that maybe had underlying symptoms and were never diagnosed or never got treated. And now they don't have those coping skills and they're really struggling. And that's, you know, I think proof to what Dina was discussing before. You go to therapy, there's so many great tools you could get that will help you throughout all of life's challenges. And, you know, if somebody is struggling, I think it's definitely worthwhile to reach out to a mental health care provider, because it could do wonders for you in all sorts of situations.
Thank you, guys. I just want to put it out there, please, if you have a question, you can type it into the chat. It's going to come to me and I'm going to relay the questions to the moderators. I might be summarizing the question and rephrasing it to make it, you know, more relevant to the group, but please type in your questions if you have one. So I have a question from somebody here. What can you do for a person that has suffered from symptoms for many, many years and has finally received the diagnosis, but is in denial or doesn't recognize this diagnosis? How can you help that person?
Anyone else want to take this? Ariel?
Sure. So the most important thing you could do is be there for them, to let them know that they have your unconditional love and support, while remaining firm on your position that they could benefit from help. And you want to avoid arguments as much as possible, but you want to make your position clear and just make it as easy for them as possible to get that support. But at the end of the day, we can't force anybody to do something they don't want.
And from a professional perspective as well, we come across this very often, especially with the older adult population, family members recognizing that they need more assistance, very often related to their mood. And so we just really want to keep emphasizing that we are able to make you more comfortable. You don't have to live with this discomfort, and we're all there, both the professionals and the people who love you are there for you and want to help you live better and be more comfortable and take care of yourself. And that obviously there's no stigma attached to that. But this is something that we want for you.
And I think, like I've said, having the education to be able to, know how to talk about, what people are going through, having the vocabulary to be able to, mental health vocabulary, I think really goes a long way if you're talking with someone about, what you notice in them. Yeah.
I also just want to emphasize what Dr. Mintz mentioned, which is that ultimately, as much as we want to try to really facilitate having people get the help and the care that they need, there are so many things happening on a personal decision-making level. And adults have to make their own decisions about how they want to live and what's important to them. And to some degree, we have to step back and allow them to do that. There are obviously many situations in mental health and in geriatrics where people really cannot understand the implications of their actions, and they don't understand the implications of not getting care. And that's a different kind of situation. But for adults who can really, they can understand what, they're making certain decisions for themselves, we have to be willing to support that.
And that doesn't mean that you can't get support yourself. So there are, certainly techniques that could be helpful in navigating that relationship. Typically, you're right, the underlying problem is the mental illness that the other person is struggling with. And the best thing is if they go for help, but if they're not willing to, certainly as a family member or friend, you could go seek out that support and, get some techniques to help maybe motivate them or to help support them through their illness.
Okay, thank you guys. Another question coming in. Did you ever find that after a while of being diagnosed that you had to try different medications or find a new therapist or take a new direction with treatment?
Sure, yeah. I mean, in terms of therapy, I needed different types of therapy at different times. When I was first finally diagnosed, I needed someone to really talk to. Just talk it out. I was going through so much that it was foreign territory to me. I needed a lot of that. Then as time went on, I needed more of a cognitive approach, learning tips, tools on how to deal with the moods and, recurring episodes and things like that. I went through a few therapists and medication. I mean, at first I was on the wrong medication. And then I've been on different types. I've been on mood stabilizers throughout, since my diagnosis. There's also some antipsychotics that I've been on because that helps with the thought circling and specifically thoughts for me, not necessarily the mood, but the thoughts are kind of associated with the mood. And I've also been on an antidepressant along with the mood stabilizer. I would not recommend being on an antidepressant alone if you have bipolar disorder. That's a horrible idea. For when my mood would dip. So yeah, it's changed over time.
Can I just say one thing, because Gina used the term antipsychotic. So I use antipsychotic medication in my practice a lot for the older population, because they actually can be safer than many other medications that are used for younger people. And I think that it really is hard to say the word antipsychotic. I think that as a society, people struggle a lot with this idea of psychosis and what is psychosis and what is an antipsychotic. And maybe Dr. Mintz could address this. A little off topic, but I just have to say, I just want to emphasize the importance of these medications and the fact that they really make a big difference to people's lives.
Yeah, I will say, so we've started to move to not call them antipsychotics, and we just call them dopamine blockers. And the reason is because, as Dr. Maureen's pointing out, people have this association with it that it's for people with psychotic disorders, which is a very scary thing for people and highly stigmatized. But, in reality, not only do we use them for psychotic disorders and bipolar disorder, we use them for depression, we use them, for delirium. There's so many different things we use it for, and it's definitely not just an antipsychotic.
Isn't there a term neuroleptic? Is that the same thing?
Yeah, it is.
More or less.
Yeah.
They're really,
yeah.
These are just a huge class of drugs that have expanded our armamentarium and taken care of so many different symptoms and concerns.
Okay, next question. Thank you, guys. How would you describe the correlation between mood disorders and substance abuse disorder?
Highly correlated. So there's, a couple factors here. So many substances cause depression, and many people with depression use substances to self-medicate or to escape or, for various other reasons. We also know that, the comorbidity is huge. If you have one, you likely have the other. And there's an ongoing debate within the psychiatric community about whether or not we should treat people with psychiatric medications while they're still using substances. And for a long time, most people said, no, because the substances are causing depression or substances are causing manic symptoms, why would you give them a medication when you know the problem is the substances? Now it's actually moving more towards the side, of course they're going to use substances, right? They're struggling so much, they're not on the right medications. How could we not help them with their primary mood disorder so that they could get off substances? And I think probably both opinions are right for different people. But, my personal preference is to treat if the medications might not have full efficacy if they're still using substances. But I believe that it gives them a better chance to get off the substances and stay sober if they're not suffering from depression, anxiety, bipolar disorder, whatever it is that's leading to them potentially to use substances.
Thank you. Okay, I have a question here from somebody who wants to know, and I don't know if anybody knows this answer from the panel, if there's a home care agency for adults with chronic mood disorders as an alternative to like a residential type of a program where they come to the home. Do you guys know if that exists?
So I practice in Connecticut, and I imagine that people are from a lot of different places. And just I can speak to the older adult population. We do have local providers who come to the home. And so I encourage you, wherever you are geographically, to reach out to your mental health or primary care providers and ask them for resources. There are resources for older people, I imagine probably for younger people as well. I'm not sure if that answered the question, but we do have access to those kinds of care, yes.
Okay. And this may be our last question because we have about 1 minute left. Are the medications for mood disorders potentially addictive? If a person has a mood disorder and an addiction because they are self-medicating, how do they get treated?
It's a great question. So physiologically, nowadays the medications we use for mood disorders are not addictive. They do not carry any physiological dependence with them. They are very helpful though. People oftentimes feel a whole lot better on them. And then they develop what we call a psychological addiction, where they can't go without it. They're a lot safer though than substances. And so from my standpoint, it's okay if they get psychologically addicted to the medications. I often try to get people off medications once they're doing well for a certain period of time based on their prior history. But the medications we use, they definitely carry side effects, some more than others. But compared to other things such as substances that people could be on, they are safer. I'm better able to monitor them. And so I am okay if they want to continue taking them.
Okay, our time is basically up. We've had some requests for email addresses to get in touch with you panelists. So if the panelists could just, if you have a place where people could reach you for more information, could you just in this last quick second say your information of how they can get in touch with you or get more information?
Sure, I'm at dina@refaenu.org. That's REFAENU.org. First name is one E up here. You can email me about anything.
I am best reached at my personal email address, which is my first name, sivia.maureen@gmail.com. I just ask that you be careful not to send any patient information or personal information just to protect privacy, and then decide later on what might be appropriate to discuss or go back to your own physician.
And the best way to reach me is at arielmintz@refuathanefesh.org, ARIELMINTZ @refuat, REFUAT, Hanefesh, HANEFESH